And thanks. And with that, it's my privilege to introduce Dr. Robert Perringer. I never knew he was a Robert. I always knew him as Spike for the past 35 years or so. Spike is a pulmonologist from originally, I don't know about originally, but who practiced at Billings Clinic for many, many years, and also an intensivist. And with that, Spike, let me turn it over to you and take it from here.
Well, yeah, I prefer Spike, and I'm a terrible boat owner too. I've only been towed 3 times in the last 3 weeks, so I have certainly a legion of faults. But what I'd like to do is talk to you, or actually people have asked me to talk about heat in the elderly. If you can either type in questions or even ask them, I don't mind being interrupted, because I think it will bring a little more dialogue into the equation. Caspin, could you forward the slide? So I'm going to start with a case that's kind of typical. And this case was presented just a year ago in the New England Journal of Medicine. I didn't really add anything. I just kind of deleted a couple things so it wasn't so long. But this is pretty typical. A 71-year-old male who has a known history of coronary artery disease, heart failure, and schizoaffective disorder. Earlier in the day, he was seen walking near his apartment complex, and then they found him collapsed. The local heat index was 105 degrees, and on arrival to the emergency room, he was conscious but confused. His home medications include Lasix, risperidone, and Corvadiol. Next slide, please. His physical exam, he was confused, he was conscious, and at that point, he was still protecting his airway, and his blood pressure was 100/70. He had a heart rate of 130, it was sinus. Respiratory rate at 28, and on 3 liters oxygen, is sat for 95%. Next slide, please. This is what he looked like when we came up to him. And the next slide. So questions I want you to ask yourself, and you may or may not want to answer, I'm fine with that. If you want to answer, that's printed out. What information would you like to see? And then how would you treat this heat-related illness? And what we'll do is hopefully I'll cover a lot of this stuff and potentially give you some insight on heat-related disease. The next slide, please. Well, here's why it's a problem. It's a problem because we're starting to see more frequently excessive heat days, and these tend to last longer, and we actually have more extremes of heat. And this is one example. Just a month or 2 ago, I think Arizona had the full month of July where they had record-setting temperatures. But the interesting thing about this whole thing is, even though we have these highly critical temperature areas and we put out heat alerts, at least in England, when they look back at it, 90% of the cases of heat-related disease in the elderly occurred outside those areas. They occurred in the areas that didn't really say that there was a critical temperature. Next slide, please. And it's not a big surprise that heat-related illness is much more common in the extremes of age, older people. And you can see the red bars are people over the age of 85. And the yellow bars are people aged 65 to 84. And this is the number of discharges for heat-related illness per million. And this was out of the National Registry. And in fact, if you take a look at environmental illnesses, heat-related illnesses are probably the most common causes of environmental morbidity to humans. The next slide, please. Well, not only is it common to get sick from the temperature and heat, but it's actually a pretty bad thing. In normal people, normal being under the age of 50, so I'm not normal, the mortality is anywhere from 30 to 50%. But once you start breaking that 50 age group, your mortality can increase to 50%. And in 2003, if you look at the French heat wave, they had like 15,000 heat-related illnesses. And their 2-year mortality was 70%. So not only did they die during that admission, but the vast majority of these people also had residual neurologic deficits. So it's actually, a fairly morbid disease and consequence. Next slide, please. Well, what I'd like to do is I'd like to describe to you how this occurs in the elderly and why it occurs in the elderly. And to do that, I'd first of all like to look at normal thermal balance and contrast that with thermal balance in the elderly and why people like myself are predisposed to it. So normally we spend a fair amount of energy maintaining our temperature, about 98.7, although I just read an article that our new normal is 98.1 or 2. And 37 degrees. And we keep it within 1 or 2 degrees by using about 80% of the calories that we have. The way I look at normal thermal balance is the following. Our body consists of 3 different areas. The core, which would be like your liver, your muscles, your heart. And it's there that we have our heat producing energy. So muscle contraction, glycolysis, gluconeogenesis, shivering, and recently, not that recently, but brown fat also contributes to it as well too. That core is then surrounded by fat. And that amount of fat varies with each of us. And that acts as insulation, but it also acts as the conduit for blood vessels, which you'll see is important, and nerves, which connect the core to the skin. Now, the skin is very important. You can gain heat from the environment from the skin. And when I think of skin, I not only think of, epidermis and sweat glands, I also think of the lining of the lung. But it also allows us to lose heat via radiation, which is the electromagnetic loss, which is our most common when we're just normally sitting around. Convection, which is heat loss with a moving medium. Conduction, which is a non-moving medium. And then evaporation, which can occur from our skin and our lungs. Now, that's both dependent on the temperature and humidity. And it's important to know that if the humidity is greater than 75%, it's actually not that efficient. So this is how we normally thermally balance. Next slide, please. Yeah, so the next one there, yeah. And so what we typically usually do is, because of our anterior hypothalamus and things we're going to discuss, is we balance our heat loss, which is evaporation, radiation, conduction, convection, with heat gain. And that heat gain can occur from the environment or endogenously. Next slide, please. So normally, our preoptic nucleus in our hypothalamus senses our temperature from the body or skin temperature. And then it sends out efferent fibers. And remember, I told you how the conduits between the fat, both the blood vessel and the nerves, are very important because they distribute the blood between the skin and that core, as well as they stimulate the sweat glands to release sweat, or in the case of breathing, evaporation, breathe faster. Next slide, please. And this is a typical picture of a sweat gland. I just got this off the web. And the difference between eccrine and apocrine sweat glands are just where the hairs are. And that's important because some of the blood vessels actually go where there aren't apocrine sweat glands. And these are called retina venosum. And they're actually on the palms of your hands, the palms of your feet, and on your cheeks. The interesting thing is when we shift blood flow normally, they actually can take up about 60% of the blood flow and work for the blood loss without necessarily, or the blood surface area for conduction, etc. Next slide, please. Well, what about old guys like me? Well, old guys like me have a problem. We don't normally balance our thermal regulation well. The reason is one, I'm older. Two, I take medications to treat some of the diseases and also to keep me awake. And then sometimes I can't move from the environment that I'm in. Next slide, please. So older people being over the age of 50, I'm saying, they don't respond as well to heat as younger people. They have a reduced ability to sense warm. So if you put them in an environment, they won't flip a switch if you tell them to flip it when it gets hot. They also get an increased body temperature prior to sweating. And that core transfer to the skin or the lungs is actually reduced and requires a higher temperature. Next slide, please. But not only that, we all take a bunch of medicines. We take medicines because I'm trying to keep our economy going. But more importantly, we take medicines as well to make us feel better. I'm not going to go through this whole list of medications, but all the medicines we have can do a variety of things. They can alter our perception of temperature even further. They can reduce our ability to augment our cardiac output and shift the heat from the core to the skin. They can actually impair sweat gland performance, and they may even increase our metabolic rate. And if you drink enough Maker's Mark, it may impair your ability to actually shift out of an environment that's too warm. Next slide, please. Not only do we have an inability to sense temperature, an inability to shift our blood, and a reduced ability to make sweat, and we're on medicines, but we got a bunch of diseases. Some of us have Parkinson's, some's heart and doesn't work and our pipes don't work. And like I mentioned, I'm impaired mobility wise and I can't move around places. Next slide, please. And this is from the paper by Sorensen a year ago. And what you can see is what I've been describing is the individual susceptibility. Age is the most important, but coexisting conditions and medications. And then the other stuff kind of makes sense. But typically we need heat exposure, but we don't need 120 degrees like it is in Phoenix. We may need just a little bit of warmth, maybe 100 degrees, and not an air conditioner. But most importantly, not in this talk, but in future talks, we'll talk about poverty and structural literacy and how that affects our ability to get away from the heat. So, big deal. What are the consequences? Well, if you heat up, what happens is remember I told you your heart, you vasodilate, your heart increases its pumping action, it increases your heart rate and your pulse pressure, and you breathe faster. Not only does that happen, you reduce perfusion from vital organs like your gut and in fact your liver, and you start developing systemic inflammatory response syndrome with cytokine release and heat shock protein release. And blood shunted away from these areas and can actually lead to multi-organ failure and DIC. Next line, please, or next slide, please. Here are some of the syndromes. I'll talk about them. I got to just look at my time here. We're doing all right. The first is heat rash, and that's a picture, and I'll re-show it again. And that's inflammation of the epidermis resulting from blockage of the sweat glands. Heat syncope is actually dizziness, and that usually occurs in people who have a limited cardiac reserve, either because they have a stiff left ventricle from heart failure with preserved ejection fraction, or those who are vasodilated, in which case the high temperature vasodilating and more causes a loss of effective cardiac output to their brain. Heat edema usually occurs in 1 to 2 days, more frequently in women, though I can attest it occurs in men too. is typically due to you basically developing a little bit of high output failure and you're compensating. Heat tetany isn't exactly what you'd think. Heat tetany, I remember when you get exposed to increased temperature, one of the things you do is you hyperventilate. As you hyperventilate, you in fact get respiratory alkalosis, which binds calcium to albumin and creates a state of functional hypocalcemia. And so people can have tetany from that. And that's different than heat cramps. Heat cramps typically don't occur when it's hot. They occur after you've exercised and usually have depleted yourself of sodium, magnesium, phosphorus, and even drank too much water and developed hyponatremia. Finally, heat exhaustion, and this is the key. These individuals have normal cerebral function, but can have anything: nausea, vomiting, headache, hypotension, tachypnea, borderline, but the key differentiator is they can think. Next slide, please. This is that heat rash again. And you can see, when you see these guys, that almost looks like they have an acneiform breakout. Interesting, where the greatest amount of blood flow is, though, remember I told you, is in the areas, the redi venosum, which are the areas where there aren't any hair. So that's where we have our greatest amount of blood flow. And I'll show you why that might be important, but I'm going to let you tell me if you think it is. Heat stroke, which is the worst of the manifestations of elevated temperature, is defined by the following. You have to have a temperature greater than 40 degrees Celsius, and it has to be a core temperature. You have to have evidence of neurologic dysfunction. Remember our first guy? He was confused. That's enough. Alteration in level of consciousness, seizures, and psychotic behavior. A lot of people say you have to have exposure to a heat stress with abnormal thermal regulation, but I'm not so sure. I know a case where they presented to me about a gentleman who was transferred to the emergency room, and his temperature was 108. They didn't have any exposure history because his mom just dropped him off at the front of the emergency room and he'd been taking medicines. But in reality, he did have hyperthermia. It wasn't realized till after he died when they actually measured the temperature in the core. Next slide, please. So the diagnosis requires a core temperature. That means you got to stick a thermometer in their rectum. You have to have a bladder thermometer or a vascular temperature. Swan-Ganz are good, but you don't really have the time to do that. And so you really do need to get a core measurement. And unfortunately, it's not very sensitive because a lot of people, when they've had heat stroke, have already cooled a little bit before they even get to you. Now, what I haven't differentiated to you, because I don't think it's that important, although you might argue with me, is the distinction between classic and exertional heat stroke. And the reason I don't think it's imperatively different, they do have different manifestations, but it's still an abnormal balance between heat intake and heat output. Okay. And then you also need a neuro exam. So a lot of athletes, you know, when they're done exercising, can get their temperature up above 40, but they're neurologically intact. They don't have heat stroke. Next slide, please. This is just a slide I gave for you to look at, and it talks about all the problems with the different ways you can measure temperature. You can put it in their mouth, which you can do, but air actually affects the temperature. You can put it under their arm, same sort of difference. But the major ones, you need to have a rectal, esophageal, bladder, or pulmonary artery pressure temperature. It can probably be a CVP temperature too. You not only need it for the diagnosis, but also to monitor the course of disease. Okay, next slide, please. In addition to heat stroke and the less complicated heat syndromes, a lot of things that I have and other people have get worse with temperature. If you have heart disease, you're more likely to have a heart attack or heart arrhythmias. you're much more likely to have a stroke, and COPD and asthma get exacerbated. Thyrotoxicosis and hyperglycemia, they get worse. And people seem to be a little crazier when it's hot. I don't know why that is. Next slide. I only give this to you and it's to only make one point. So each of the less important things on the heat-related illnesses and the others, this is a logarithm that you can use to treat them. But the big thing is, the first thing you think of when you see these people is cool them off. I don't care what it is. People have talked about scoop and run for trauma. This is different. You cool and run for hyperthermia. So if it is exertional heat stroke or exertional problems, you get them wet, you take off their clothing. There are some other things you can do to cool them off that we'll talk to you about, because the reason is the most significant treatment you can give for these individuals is cooling them off. The faster you do that, the least morbidity and mortality. Next slide, please. So with that said, the treatment is, you got to think about it. As I mentioned to you, that guy that was dropped off at the emergency room, they did CPR on him for an hour and a half. They did great stuff. They did CPR, they had cardiac echo that showed no cardiac activity. He's a young guy who had been doing ecstasy and 2,5-dinitrophenol with his mom someplace. And she just dropped him off. And you know why they kept doing CPR? They did the echo and they looked at it. They did it because he was still warm, and they thought, well, he's still got to be alive. I'm just not doing my echo right. I got a call about 6 hours later. And they said, because he'd already died, and he was in the morgue, and they said, this guy's still hot. And that was the first temperature they took. And so the temperature at that time was 108 degrees. God knows what it was when they initially did it. These were really good docs. And they did a great job, except for they didn't take the core temperature. They did an arm temperature. And if you don't think of it, you're never going to find it. The best treatment, literally the best treatment, is prevention. When people come in with heat stroke or heat-related disease, I consider it a failure of the village. You know, that old, I don't want to be political, but it takes a village kind of deal. Well, when you look at people in England, 90% of the deaths occurred outside of the heat wave alert areas. So you not only got to think of it outside of it, but in fact, you have to prevent it in the most susceptible people. Old people on medicines, who have other diseases, and in fact don't live very well. So how many of you people actually identify people who are at risk for heat-related illness? Well, I can tell you no one's ever asked me about it, and I'm 67 years old. I look 90, but I'm 67. And no one's ever asked me about those things. And likewise, no one's ever counseled me what I should do if it's too warm. Finally, the other thing is not only do we have to identify and educate people, and I've given you some references what you can do to educate them, and it's common sense. Drink lots of water, you get in air-conditioned buildings, you avoid the heat, or exercise in them, especially if you're older. But the other thing is a lot of us live alone. I mean, I'm kind of a hermit. I live where I live without anybody visiting me. And in a village, we used to have people that were nosy, that if it was a temperature greater than 95, they'd be coming to see if you were all right. And if you look at this guy, the presenting guy that we had, the prevention could have been, he lived in an apartment on the top floor. And he was out there walking, and no one really even noticed him until he was lying down, passed out. So as a village, we don't need to really be friendly with all these people, God help us. But what we can do is we can check in on them. And we need to do that. Well, anyway, that's my little pitch for prevention. And so when it gets hot, our community, not just our doctors, our nurses, our community needs to know who's at risk and go check them out. Just go see if they're doing okay. They don't need to wait 3 or 4 days till they're moribund. Finally, I'm going to show you some strategies for rapid cooling. And most importantly, we need to rule out other causes that can cause this. So the most common everybody hears about because of exercise-associated hyperthermia is throwing people in a cold water ice bath. That works great, but can you see having to monitor someone like that in your emergency room? Especially if you throw me in a cold water ice bath, I'd rather die sometimes, you know what I'm saying? And so the next slide, please. And the interesting thing is ice immersion is equivalent to cold water immersion. So what you can do is you can put a person in a body bag, slice it open, throw some water behind that and pour cold water over them, get them naked, and just throw warm water on there. Why do you throw warm water on them? Because it evaporates with a greater caloric loss than, in fact, cold water. The other thing that's real simple to do is keep a liter of saline in the fridge. Well, the reason being is that some people argue is we want to get that core temperature colder faster than the peripheral temperature. And a liter of cold saline, that's how I cooled people when I'd cool them off. I know a lot of you guys have this Arctic sun where you paste it on them and they do really well. That takes too long. By then you fried their brain. So what you need to do is work fast and quick. Next slide, please. This is the classic ice cold pack placement, right? You do ice cold packs to the neck, the armpits, and the groin. That's another way to do it. However, the interesting thing, remember I told you that 60% of the blood flow when we are shifting from that core to the periphery goes to our palms, our cheeks, and the soles of our feet. Next slide, please. This is an interesting study, and I'm just looking quick. And it's interesting for a couple of reasons. They took 10 guys who were in the military, and I think this is the only place you could do this. And they stuck an esophageal temperature probe down each of them. And they had them put on these big rubber outfits and hiking thing and run on a treadmill until they got their temperature up to 39 degrees. And so the first thing they did that, and then they had them step off the treadmill. And if you take a look at the open boxes, you can see at 30 minutes, their temperature is still pretty high, isn't it? The lightish gray boxes are those that actually put ice packs on their groin, their armpits, okay, like we usually do in the ICU and the ER. And you can see they dropped about a temperature. But if they just put them on the soles and palms of their hand and their cheeks, they had a much more rapid rate of loss. So in fact, when we're doing this, we have to think about it. Now, I don't know about you, but I went fishing last week and I got this big fish. It must have been 10 inches long. But anyway, when I was hauling this fish in, 8 or 9 people were hollering, keep the tip up, do this, do that. Do you think I could do anything right? Because no, everybody had an opinion. And here's the reason why I'm telling you this, is the reason is you need to have, depending on your emergency room or wherever you're at, you need to have a set protocol on what you're going to do in that situation. Maybe practice it once. But if you have someone saying, slap the gloves on, put an ice pack on and put them in the body bag, it'll go much faster than one person telling everybody to do it. So having a protocol ahead of time, I think is key to doing this quickly and fast. Next slide, please. Another way to cool people off, and I kind of like this one, is especially with high flow, now the COVID, you can turn up high flow to 20 to 40 liters and evaporate quite a bit off of people pretty quickly. It's uncomfortable because 20 to 40 liters without humidification doesn't feel good. But in fact, you can cause a significant amount of evaporative loss. And this is just a device they have, but you don't even need to buy this device. You can just put a nasal cannula and crank it up. And that'll help you because you're breathing faster, you're losing water from your lungs. Next slide, please. And then there's evaporative cooling. I was a big proponent of this about 10 years ago. The problem is my infection control team appropriately slapped my hands because it also could cause spread of infection. But if you don't have a fan that big and you spray tepid water, not necessarily cool water, you can enhance your cooling. Now, how far do you cool? Well, everybody says 38. Do you know how many studies there have been in hyperthermia? Well, not very many. So this is just consensus. And in fact, a case study looked at cooling people to 36 like we do post-cardiac arrest. And it was only small, 5 or 6 patients. And they seem to get better outcomes. But whatever you're going to do, I mean, do it in a group, talk about it, set it down in stone, and then do that. We're going to go to 36, 38, and that's what we're going to do. You're not going to be wrong. Wilderness medicine says to go to 38. And I think that's an appropriate thing. And if you do it rapidly, they'll probably do okay. But I don't think anybody knows for sure. Next slide, please. There are some invasive things you can do. You can do bladder lavage, gastric lavage, and you can do ECMO. And you can do intravenous, which is what I think is a good fast start because it also cools the core quicker. Next slide, please. What about shivering? Everybody gets cold. Well, if you can keep the temperature above 13 degrees Celsius, you won't get vasoconstriction in all of these body parts, okay? And if they're shivering, it's not recommended to do aspirin or Tylenol because of their side effects. One of the things that can cause this is malignant hyperthermia, and some people have suggested using dantrolene. There's a study ongoing now, but it only shows that we can cool them faster and not necessarily affect their morbidity. Benzodiazepines are useful for shivering, but it also affects your mental status. And if you get individuals down to 38, they tend to wake up, and it helps you figure out your differential because a lot of people can have elevated temperature for reasons other than hyperthermia. And then there's the central 2 stimulants. Next slide, please. So what information would you like to see? Well, the information that I would like to see is a core body temperature. How you do that depends on what are your resources. That's in the acute setting. What I'd like to see in the chronic setting is that you identify the people at risk for heat-related illnesses. You educate them about what to do. And you get a community. You don't have to like each other, but you have to care for each other. And you have to help each other out and look after each other during these times. How would you treat this heat-related illness? It depends on where you're at. You know, if I'm at a run and they're exercising and they're hot, I take off their shirt and throw hot water on them and let them sweat. And if I have an ice tub, I throw them in it because they're young people. If I have an ER, I might put them in a body bag. I might use tepid water. I'm certainly going to give a liter of cold saline, but I'm going to be prepared. And it depends on where I'm at and what I have. Okay, but I would be prepared ahead of time. And I do it quickly. Next slide, please. So in conclusion, old people are susceptible to heat injury. They, in fact, can't detect heat. They can't shed their blood from their core to their periphery very well. And in fact, they don't sweat very well. They have medications that impair all of that. And in fact, they have common diseases that impair all of that. The core temperature is a vital sign. The most common mistake an intern does when they call me in the middle of the night is they'll tell me, this guy's really sick, I think he's going to die. And I go, what is his vital signs? They go, oh, and you know what? They're vital. And that core temperature is vital too. So prevention and then followed by rapid cooling are the essential features. The rest is just some other stuff. That's all I got to say.
Okay, great. Thanks, Spike.
Yeah, did I keep it under?
Oh, you got plenty of time. Strong
Okay,
work.
good.
Put you into a rare group that keeps it under time.
Well, I tried to. I'd rather talk about it because, say, I'd like to see what other people's experiences with are and what they do to cool people off. Okay.
Yeah, I appreciate that. We'll open it up to questions, and folks can just unmute themselves and ask a question. And it's, I mean, a lot of the points you made, not only about the people that are high risk and talking about the elderly for a variety of reasons, but also many of the interventions that you suggested are things that we can start even if we're not in the hospital or in the ER or in the ICU. And it gives great perspective on that. So thanks. So let's open it up for a few minutes, see if folks.
The one thing that I didn't really focus on too much is, you know, when I'm hot, I go sit in the shade. And so putting people in the shade out of the hot is a simple one, behavioral, you know. How many of you guys have protocols developed already where you live? And I'm not saying ones that the head nurse made and then put in a spiral notebook, ones that you know.
You know, I think a lot of the people on the call are, we have some sanitarians, environmental health people, some public health people, some academic nurses, medical students. So I'm not sure people are going to be too aware of protocols. Some of them might.
Right. Well, and they should maybe develop them for their region.
Yeah, a pre-hospital protocol for extreme heat exposure from public health departments and environmental health departments is probably.
Well, and also, Spike, one thing you pointed out, which is, you know, coming at it from somebody who's worked both in the hospital, but also a lot more in clinics in primary care, and that is just letting people know that they are, I hate to say at risk, but that's the bottom line of,
Yeah,
you need to think about this, because if you're whether it's a physician or nurse practitioner or PA or nurse or whoever talks with you doesn't bring it up, then most people don't think about it. And certainly this is very different and a bigger issue than I think most of us recognized 10, 20 or 30 years ago. And it's become
I agree with
an issue.
Nancy, I love what you said in the chat that just, educating elders, most people just aren't aware of the significant health risks.
That is really nice.
Hello, Doctor. Could you hear me?
We can.
This is Olivia. Oh, thanks. I'm on my phone. So first off, thank you for the presentation. It was really great. And I'm working at the Fort Peck Reservation in Northeast Montana and trying to help with climate. But a lot of that is, we're looking at a lot of behavioral and community initiatives. Do you have any resources or experience on how to organize these kind of community campaigns beyond the hospital to spread awareness, especially with people with low access to healthcare? Or are there things you know that don't work very well when talking to the public?
Have you talked to that tribal council?
Not about this specifically. We're just getting started. So.
Yeah, so they have a lot of influence there. I know Rob has a lot of experience working with the Native peoples. Do you have other thoughts, Rob?
Yeah, Olivia, that's such a great question. And that's actually one of the kinds of things we were going to talk about between 7 and 7:30, but I think we can jump in here. You know, when people who are doing climate change work in the health sector, especially, although other sectors get involved with this too, one really helpful thing is identifying cooling centers. And if you're in other states, like if you're in Oregon, you can call 211 and they will tell you where the nearest center is, and then they'll actually send transportation to pick you up. Well, we obviously are not quite that organized in Montana. But there are a couple places that have started having cooling centers, not many. And so I would actually love to hear and there's a couple other initiatives, but I would love to hear from anybody here if they're aware of any cooling centers in their area. And so a cooling center is just simply a building somebody's given you permission to use. It's usually not a special building where the temperature is cooler and where people can go if they don't have the resources to stay cool. So does anyone's community have one that you know of?
We actually have a brand new one.
Wow.
We had a new wellness center made, and actually that's been a core part of my concerns going forward with climate is trying to create a network of local shelters, because out here on the reservation, we're at 0.0004 people per acre. And so even if the roads are good enough to get an ambulance out,
right.
Local shelters, but that you just brought up a really good point, made me think of if people are willing to volunteer for this, giving them some training and tools, you know, say teaching them cheeks and palms instead of groin and armpits might be a good way to train laymen to do some of this in the absence of medical professionals. So, thank you.
Yeah, Olivia, that's great. I mean, just to point out, and for Spike, for you and for everybody else, that's the first time I've heard that as well, and it's you know, extremely helpful. I mean, that's very practical. But Olivia, I think a lot of us understand it's different if you're doing this either in a hospital or in a city versus rural Montana or beyond rural, which is frontier Montana, which is the norm. You know, if we have to send the ambulance, we're already behind the curve. So trying to get that information out there and helping people become more aware and preventing the problem, which is not easy. As temperatures go up and you don't have air conditioning, it's hard. But yeah, that's the discussions we would like to start and share with each other of how we're dealing with this, or have we found some solutions or answers or things that work.
A couple ideas that other cities have done. They actually are building a specific clean air and cooling center in Missoula, but it's going to take a couple of years to get off the ground. We just found out recently that in Red Lodge, they have identified 6 different centers, smaller places, and none of them were big enough to house, you know, potentially all the people that might need it if you had a super heat wave. But that was a progressive thing to do. And in talking with some of the people at Riverstone, not you, Deb, but a couple of your colleagues, they were discussing having conversations with the various people in town that work with under-resourced people. So for example, the homeless shelters and the food services, those kind of things, and trying to get each one of those groups to identify a place that would be big enough for the population that they serve. Another conversation. Oh, sorry.
They're talking about the mall and some of the big air-conditioned spaces here in town. And it's more of an educational thing so that people think about it and have a plan for when the heat does hit.
Right. Yeah. Thank you. And another thing we were talking about, and they do it in some places. And Olivia, this is something that I think could be a possibility with Indian Health Service, is a lot of, some places have a texting system. So they've identified at-risk populations. So they might define elderly as over whatever age. And so then they can actually send text out. Now I realize where you are, especially the elderly patients, a lot of them don't have phones, but it is a way to remind people and to warn people. And so various places look at, you know, depending on like the pregnant population is an easy one because they're also at risk from heat. And it's pretty easy to find all the people that are pregnant in your system and send them a text. And they are more likely to have a phone that you can text to. But that is a possibility too. And then in towns where you have, depending on what you have, but some places have their own local radio station, that kind of thing, getting public service announcements, especially when you're going into a heat wave, because most of the time we know that one's coming.
But
No,
you know, that's
great.
why I think you need to have something background, because the majority of the people that get, you would think it would be in the hottest areas that they get sick. It's not. It's usually in the remote areas. I'm wondering if most of the people where you're working, Olivia, they have very strong family bonds. Could you have the families be a center of it?
Unfortunately, yes and no.
Okay.
There's a lot of drug problems, generational, that have made family structures difficult, but targeting schools has had something of an effect. You know, teach the kids or tell the parents when they get there, because that is a gathering place for the community in a way that other places might not get that much of a draw. So that's definitely something to think about, because I don't know details on that. Although, as a quick little idea aside, that ties into this for anyone else who's in community planning. Part of it is all the energy and green grants and resources coming down the pipe. One of the ideas that was floated here in regards to those community identified houses, you know, cool shelters, is if a house receives assistance in the form of extra energy, you know, renewable energy priority or cooling priority, then in turn their payment, quote unquote, for that is to plan ahead to have a room open. So they have to be willing to, that community trade-off where you don't have to like each other, but you have to care for each other in the sense of, so that's not related to any specific other initiative. And I agree that overall the prevention and general education should come first, but just throwing things at the wall and hoping they stick.
I think it's worth knowing when we were working on the Climate Change and Human Health Report in Montana, even in small towns, there are heat islands. I know where we live in Hardin, you go over to where the trailer courts are and it's way hotter than it is in other parts of town because there's fewer trees, there's more concrete. Yeah, so even in small towns, there's areas that are worse for heat. And then I think we also have to realize that a lot of us have the luxury of living in a house that has decent insulation and that has some ceiling fans and that kind of stuff and has some greenery in the yard. And you know, you can live with it 100 degrees and be pretty comfortable. But if you're living in a crummy little house with poor insulation, sometimes it's hotter inside than it is outside. And if you get a point above 95 to 100 degrees, fans don't really even help. So it is a real problem for other people when we might think we're doing okay because we're younger and healthier and live in a better house. So, and then you also have the issue where some people might have air conditioning in their house, but they can't begin to afford to run it. So.
I think one of the issues that make this a little bit hard in terms of making people aware is if you compare like to the air quality where you have flags that tell you the air quality. But because of the inequality in housing and all of the other factors, it doesn't make it simple to really identify when you have what is a heat wave? What temperature identifies that? And how are you going to set up a warning system that's effective? That's my question.
Yeah, in different places define it different ways. I guess my experience has been more with pregnancy. When you look at the research on pregnancy, which we will discuss in another of these talks, but most of the research have been done looking at exposure to 85 for a few days or 90 for a few days. So again, it's not those super heat waves. I mean, those are even worse, but even lower temperatures put mothers and their fetuses at risk of increased complications, being born premature, those sorts of things. Yeah, so I guess I don't have a magic number on that, but I think just taking a number and going with it and just letting people know, I think part of it is just the community education. Like if you started a texting session, a texting system or, a PSA system on the local radio or something, just choosing a number and going with it. When it's above 85, let people know they're at risk. And I think most of them, if they are hearing warnings that they're at risk when they're above 85, they realize they're also at risk when they're above 90 or 95. So, but a lot of this is education.
Yeah, and another aspect of that is more and more places are developing, and some call it resiliency plans, some call it other things, but they take into account the fact that, well, only a certain segment of the population listens to radio, and only a different segment of the population looks at social media. So how do we let folks know that are at risk, to both make them aware that either something's coming or that they are at risk, or to contact them if problems come up and check on them. So it's very hard. There are no perfect answers, and there is no single answer. But certainly having local discussions and developing plans around this makes a difference. And certainly a lot more communities are doing that. And that's one big part of it. And that includes discussions of things that people brought up of, well, we don't have, we have a limited, say, EMS service, or huge distances to deal with a small population. That makes it dramatically harder, which makes those local discussions even more important, especially when we're all limited with resources, be it money or other things. But and hopefully, as we start to become more aware, we can make some inroads on this and help people stay healthy and become more aware of their risks.
I think kind of alluding to what Spike said, that just checking on our neighbors, kind of common sense would be very helpful in this situation. 85% of our health problems are treatable outside of the exam room. So you don't need Rob and I and Spike to do a whole lot for your health or a whole lot for your neighbor's health. And so housing comes into that too. Again, a lot of people have substandard housing. And so there are things that others in the community do. And I know in some places sanitarians support this. I know some of the environmental groups support people with housing issues, but there is some funding available. And there is funding through IRA, of course, to do energy efficiency, which means insulating your house more. And those things actually help people be more resilient. There are programs, not a lot of money, but there is programs even through Northwest Energy and through some of our co-ops to help lower income people work on their houses. Olivia, way better than we do. I know it's very complicated when you rent. And so on the reservation, there is always even more issues, but there is some money available out there, and those sorts of things do help our homes. And planting trees around our house helps our homes if we have enough water. Doesn't help me for this year, but over the coming years, it does help. So.
Thanks.
Is anybody in the hall on public health, in public health?
Alice speaking.
Okay,
Yep.
thank you. Have these issues ever, what county are you? I don't know where you are.
I am not, I guess working for like a health department. It's a public health consulting organization. So we help, I guess we get contracted out to do different work around the state. So I don't have any clinical experience, I guess, but I just came to learn more about it because my actual education is in environmental studies, but now I work in public health. So finding that intersection is very interesting to me.
Wow, great combination there. And just before we forget, because I know you'll get busy and some people will drop off the call. If you need nursing and sanitarian CE for tonight, or if you just want to be a nice guy and do the post survey, it just takes a minute and a half. Casper, if you would re-put it in the chat, because I think there might have been 1 or 2 people that joined after you had it in the chat.
Sure, 1 moment.
We'd love to have you
Yeah.
fill out. And
I just want to thank Caspen for all his work and helping me out too.
Thank you, Rob, and thanks for your patience with me as I figured out how to do that. Thank you.
And a special thanks to you, Spike, for this. And the other thing I'm going to point out, you mentioned it both in your talk and in answer to the questions, but the data that suggested that at least in England, many of the people who were impacted were outside of the those, I want to say, protected areas or areas that were, could get the apps or could get the warnings. And certainly that speaks very highly to what many of us deal with in Montana, is that, yes, a large segment of the population is outside of all of those umbrellas, and figuring out how to let those folks know and how to help them is an ongoing challenge.
Olivia, I'll look for, there are a couple other groups that have done resources. We're in the middle of creating an education campaign with the Montana Health Professionals for a Healthy Climate. But we have not tackled the heat topic yet. We have it on extreme, we have on the fires and smoke, and on pregnancy, and heat and drought and mental health are the other issues that we're tackling, but they're not done yet. But there are some other people that have some good, at least brochures and resources, things you can download, and you might find them helpful. So I will dig a few of them up for you.
Okay, thank you. I really appreciate it, mostly because I've written down stuff and I know I'll look at the recording, but if I'm going to bring this to council and the other IHS members, I have an understanding of medicine. My mother was a clinical physician growing up, and I'm a nerd, but I have no background to have authority. So being able to point the healthcare workers towards something, something with more authority, or someone with more authority to.
You can have them call me
to
anytime.
relearn this.
Yeah.
Thanks. Thanks.
Yeah, I'd be glad to serve as a resource for you if you need it.
I might take you up on that.
Oh, no worry, I'm old. I don't have anything else to do.
Yeah, and Olivia, the same applies to Lori and I, and also through the organization Montana Health Professionals for a Healthy Climate. We have a lot of contacts across the state that we may be able to get somebody locally, which always is nice. If not, like between Spike and Lori and myself, we're happy to help out in any way we can.
I appreciate it a lot. Thanks.
There's a couple of you on the call. I'm not sure if you have subscribed to our newspapers in the past. We would love for you to newsletters. We would love for you to. I think we have about 900 people on the list now. Not all of them are healthcare providers. They're people who are concerned about the effects of climate change and air pollution on our health. But we feel like as we try and work with state government and work with legislatures and work sometimes with cities and counties and tribes, we have a little more clout with more people concerned in Montana. So if you're concerned, sign on with us, and we would appreciate that.
Have any of you guys heard about the trees? And there's a tremendous amount of money to plant trees in communities here in Montana.
You all just got a $1 to $2 million grant in Billings.
I know. I just wondered if anybody had any ideas in communicating to get some input on where they put the trees, or thinking about using them as sort of natural cooling centers for where our homeless congregate and such. But has anyone done anything with that?
I'm not sure in Montana, but I know you have a city forester, and he is really aware of all that stuff. I know he's worked with the mayor's energy commission, and they are definitely looking at like the south side of town. He also looks at besides getting shade trees and trees that'll grow well in Montana, he's also really into edible landscapes too. So that's a really exciting move for Billings, and it could make a big difference in
It really is. I was amazed at, and he on the news, it was like, well, they don't even quite know how many trees that is with that much money. Or I guess the biggest challenge is how to take care of those trees and keep them going early, because that's a chore, getting things established when we have these really dry. Even now, even though we're over in precipitation over normal, it's still, the soil has gotten dried out, and plants are suffering. If it freezes, things are going to die. So, but anyway, I just wondered, because I think that's pretty exciting.
yeah, it is.
What's his name?
I don't remember, but I can, I have a friend that's on the Energy Commission. I can ask her. He actually talked before, gave a talk that I heard, but I forgot his name.
Well, I'm sure I can find it, but I will bring that up in our committee to see if anybody is interested in maybe interacting some, if, looking around in the south side, the skate park area.
Right.
Huge number of people hang there.
I've heard in some places it's a real issue when you, even if you have trees that you're willing to plant, and even if they're sizable trees, that kind of thing, that if it's on people's property, then they have to buy the water, which of course is substantial in Billings. So hopefully some of that funding can go towards helping people plant trees.
Maintenance. Yeah, that would definitely help, I think, if people would be, yeah, that's a good idea.
Well, I think we've kind of covered heat pretty well, gone beyond the elderly tonight. And I think there's other conversations we will, definitely cover in other nights. And also we'll do the CE after the December webinar. You don't have to attend that one, but just, it'll be kind of for 2023. And then the 3 webinars that fall in the spring, we'll do a 2024 certificate that will mail to everybody that requests one. So we really appreciate all of you being here.
Yeah, thanks everybody. And thanks Spike so much. We very much appreciate it.
Well, thank you for having me. I appreciate it. Have a nice day, everybody.
Okay.
Nice to meet you.
Thank
Take
you.
care of that dog. Okay, Robin?
Thank
Take
you.
care, everybody. Be safe.
Thanks for the presentation.